Hello and welcome. Thank you so much for joining us. I am Laurie Jones, the Managing Director of ME Action. ME Action is a nonprofit organization that is dedicated to advocating for and with people with myalgic encephalomyelitis, or ME/CFS. ME is a devastating condition that affects millions of people around the world. 80% of people develop ME post-infection, with an increased number of people developing ME after major viral outbreaks. A year into the COVID-19 pandemic, we are unfortunately welcoming new people into our community that have had long COVID and are now being diagnosed with ME. So that makes today a crucially important conversation for the millions more developing ME, for the future of research, and for the understanding of the general public. We have a terrific panel set to speak with you today, and moderating this conversation will be ME Action's Director of Scientific and Medical Outreach, Jamie Seltzer.
Thank you, Laurie. We're excited to present our panelists, each of whom have unique insights to offer about long COVID and its relationship to ME/CFS. They're researchers and clinicians who have spent years investigating ME/CFS and people with lived experience of ME/CFS and long COVID. First, I would like to welcome Dr. Lucinda Bateman, MD, who is the founder and medical director of the Bateman Horne Center. Hello. Next, Dr. Anthony Komarov, MD, is the Simcox Clifford Higbee Distinguished Professor of Medicine at Harvard Medical School and a senior physician at Brigham and Women's Hospital in Boston. He is also the editor-in-chief of the Harvard Health Letter.
Hi.
And Dr. Avindra Nath, MD, who is the Intramural Clinical Director at the National Institute of Neurological Disorder and Stroke, NINDS. He is the lead investigator for the NIH Intramural Post-Infectious ME/CFS study and has recently launched 2 intramural studies to investigate long COVID. Hello,
Thanks
Dr.
for having me on this panel. Thanks.
Absolutely. Next, Jen is an RN who got COVID-19 in March of last year while living in Seattle and is now showing symptoms of ME/CFS. Welcome, Jen.
Thank you.
And finally, last but not least, Ashanti is an RN living in LA who got an enterovirus in 2016 and has a diagnosis of ME/CFS. She has spent the last 5 years advocating for change. Hello, Ashanti.
Hello.
Hello.
Happy to be here.
Thank you. And so first on our docket is a conversation with Dr. Lucinda Bateman. Cindy, take it away.
Thank you very much. It's a pleasure to be here. I want to provide a quick overview of ME/CFS, myalgic encephalomyelitis, chronic fatigue syndrome. And as we've heard, it's a chronic debilitating illness, often post-viral. It's very uniquely characterized by impaired ability to function, less tolerance for activity, and that can be physical, cognitive, and upright activity in association with fatigue. But even more important, patients experience post-exertional malaise or a relapse or increase in illness symptoms after attempting to engage in physical, cognitive, or upright activity. And the consequences of post-exertional malaise may last several days or even weeks. In addition, the core symptoms of ME/CFS include sleep disturbances, cognitive impairments, and orthostatic intolerance, which is a big word that just means symptoms escalate when upright and they improve when lying down. There are many causes of orthostatic intolerance, including deconditioning, but the most insidious is disease of the autonomic nervous system. And this manifests as hypotension, tachycardia, and a myriad of symptoms in the upright position. And ME/CFS patients also frequently experience painful headaches, muscle or joint aches, and allergies and sensitivities. And the cause is often unclear because the diagnosis is often delayed for months or years after onset of their illness. We are observing many overlapping symptoms between long COVID patients and ME/CFS patients. And you may have reviewed the preprint that was available in late December. That's an international web-based survey of suspected and confirmed COVID cases with more than 3,700 respondents from 56 countries, mostly the US and the UK. And even more importantly, most of the participants were not hospitalized with COVID, yet 3/4 are reporting symptoms suggestive of ME/CFS after 6 months. And the most frequently reported symptoms by these long COVID patients were, and this sounds familiar, fatigue, post-exertional malaise, and cognitive dysfunction, along with a significant amount of chest symptoms, tachycardia, dizziness, insomnia or sleep problems, and headache, muscle or joint aches. And most had not returned to work by 6 months after their acute illness. I'd also like to share with you the observations of the first 12 long haulers that we have seen in our clinic in the last 2 months. And I can't say this represents all long COVID patients because these patients are self-referred and came to our clinic after viewing our education materials or attending online support groups. So they may have felt like they had ME/CFS symptoms. But of the first 12 patients that we evaluated, there was 1 male and 1 female. Their average age was 44. It spanned age 32 to 59. 9 of the 12 had been sick since the onset of the pandemic, 10 to 12 months. And we saw 2 that had been sick more than 6 months, 6 to 7 months, and 1 who'd only been sick 4 months. But 10 of the 12 patients meet ME/CFS criteria after careful evaluation. 2 were severely impaired, and but most were moderate. And moderate, by definition, for ME/CFS means still unable to maintain full-time work, but able to have maybe 2 to 4 hours of light upright activity tolerance during the day. Interestingly, 9 of the 12 met criteria for POTS, postural orthostatic tachycardia syndrome, and 2 had milder forms of orthostatic intolerance based on standardized the 10-minute Nasaline test, bedside testing. And 50% of these patients met the 2016 American College of Rheumatology criteria for fibromyalgia, which scores widespread pain, chronic fatigue, unrefreshing sleep, and brain fog. And some of the patients were very, very severely impaired. So we suspect a small fiber polyneuropathy in about half of these patients, and mast cell activation syndrome, a severe kind of allergic response in more than half of the patients, and look forward to doing more testing. So basically that's my summary, and I'd like to hear the comments from the others, and then I'll take some additional questions.
Thank you very much, Dr. Bateman. Next up on our list is Dr. Anthony Komarov from Harvard Medical School and Brigham and Women's Hospital in Boston. Dr. Komarov?
Thanks so much for inviting me to join you. Let me start by saying that when I use the word COVID, I'm referring to the illness COVID-19, and I'll talk about long COVID just as Dr. Bateman did. I want to address briefly 4 questions that were put to me. The first is, was a post-COVID lingering illness predictable, and why? And the answer is yes, it was. Similar lingering fatigue syndromes have been reported in the scientific literature for nearly 100 years, following a variety of well-documented infections. Infections with viruses, with bacteria, with fungi, even with protozoa. Such an illness follows SARS, for example, which is caused by a coronavirus very much like the virus that causes COVID. So it wasn't surprising when Dr. Fauci, other doctors, and patients began last spring to talk about how some COVID patients seemed to be developing a lingering, fatiguing illness. COVID appeared to be another example of a post-infectious fatigue syndrome. As Dr. Bateman pointed out, long COVID is also very similar to ME/CFS. There are some differences. From my reading of the literature, the long COVID patients are more often to be breathless, for example, and certainly more often to have disorders of taste and smell. but many of the symptoms are quite similar. With ME/CFS, very many of the patients, not all, but very many, say that it began with some sort of infection. They call it a flu, a cold, a virus. It seemed to be at first just like a normal infectious illness that would pass. And so the doctors didn't really do tests to document that there was an infection and what the infectious agent was, but it certainly seemed like an infection. They had sudden onset of respiratory symptoms, gut symptoms, fevers, swollen glands, seemed like an acute infectious-like illness, but no documented infection. So that's interesting because of the many instances of very well documented infections that are also followed by a lingering fatigue syndrome. Second question, how many people who get COVID are going to go on to develop long COVID? And what is that going to mean for the world? Of course, we don't know the answer yet. And I'm better at predicting the past than predicting the future. But there is some basis for making estimates of what's going to happen. So first question, how many globally are going to get COVID? As of today, there are about 125 million cases. So let's assume conservatively that by the end of 2021, there will be 200 million cases of COVID globally. How many of those 200 million are going to develop long COVID? There have been some careful studies of several different infectious agents. And one study in particular 15 years ago of different kinds of infectious agents found that 10% of patients a year later still had lingering post-infectious fatigue syndrome. So if 10% of 200 million cases of COVID develop for at least a year a chronic lingering post-infectious fatigue syndrome, that means 20 million cases of long COVID will appear in the next year. Third question, can what we've learned about ME/CFS help understand what causes long COVID? And vice versa, can whatever is learned about long COVID help understand ME/CFS? I think the answer is going to be yes, because the two illnesses are similar enough in their symptoms that it's fair to think that they probably share a similar underlying biology, although that remains to be shown. So what do we know about the underlying biology of ME/CFS, which has been around a lot longer and been studied more up to this point than long COVID? We know there are multiple abnormalities of the brain and the autonomic nervous system, which controls vital functions of the body, like heart rate, blood pressure, and other things. We know there is sort of a combination of activation, dysregulation, and exhaustion of different parts of the immune system. We know there are abnormalities of metabolism, particularly energy metabolism. In other words, in the person who feels like they don't have enough energy, there is growing evidence that that person's cells are not able to make adequate amounts of the energy molecule, ATP. There is a state of chronic oxidative stress. And finally, there are probably abnormalities of the gut microbiome, the bacteria and other microbes that live in our gut. Some of these need more study, and most important, we need to understand how all these different abnormalities affect each other, because they almost surely do. Fourth question, am I optimistic that we're going to make real progress in understanding both long COVID and ME/CFS? Yes, I am. Fortunately, I think we're on the threshold of learning a lot more about both of them. First of all, in the US, in the past 5 years, the NIH already has substantially increased its funding for MECFS. For example, NIH has funded 4 centers around the country dedicated to the study of MECFS, such as the one at Columbia with which I work, and others at Cornell, Jackson Laboratories, one in Canada, and affiliated institutions like the Bateman Horn Center working with these other centers. This network of collaborating centers is described on a website if you're interested, mecfs.rti.org. Going forward, governments all over the world are committing large investments, both in the UK, US obviously, UK, Canada, Netherlands, I learned yesterday, substantial funding to study the consequences, chronic consequences of COVID. NIH has recently announced it's going to be dedicating $1.1 billion over the next 4 years to studying the chronic illnesses, that's plural, that are likely to develop following acute COVID in some people. That's a huge investment. And I emphasize illness as plural because, in my opinion, there are going to be shown by research to be several lingering illnesses following COVID rather. Some people are going to be left with lasting damage to their lungs, others to their heart, others to the kidneys, others to the brain. And in some of these people, that lasting damage is going to cause symptoms that impair the ability of those people to function. Some of those symptoms may include fatigue and other symptoms that we see in long COVID, but those symptoms may have different causes in those people, like an inability to get enough oxygen through their lungs and into their blood, for example. People with long COVID may not have lasting detectable damage to their lungs, heart, kidneys, but they will be left, nevertheless, with fatigue and the other symptoms that Dr. Bateman described. It's my bet that long COVID is going to prove to be caused by certain kinds of abnormalities in the brain. Some of the same abnormalities that have been already identified in MECFS. Research is going to determine whether that's right or wrong. It's my hope and strong recommendation that the abnormalities identified already in MECFS be included in any studies of long COVID, and also my hope that in any studies of long COVID, there be comparison groups with MECFS studied alongside the long COVID patients. NIH, as you're going to hear from Dr. Nath, has underway in its own laboratories a number of studies, both of MECFS and long COVID. CDC is also going to be increasing its studies of long COVID and hopefully MECFS. And finally, private foundations, ME Action, Solve ME, Open Medicine Foundation, are providing really important support for research in all of these areas. The huge investment by NIH already is attracting many scientists into the study of MECFS and long COVID, scientists who previously focused all of their talents on totally different medical illnesses. And because of that surge of both financial support and talent, I think we're likely to get some fundamental answers to both long COVID and MECFS in the next 5 years. And by fundamental answers, I mean good diagnostic tests and some effective treatments. So every cloud has its silver lining. The increased focus on post-infectious fatigue syndromes is a silver lining, in my mind, around the terrible dark cloud that is the pandemic of COVID. Thanks very much.
Thank you. Thank you very much for that, Dr. Komarov. All right, now I'd like to introduce Dr. Nath from NIH.
Thank you very much, Jamie. First of all, let me just start by saying that both Dr. Bateman and Dr. Komarov have done a superb job explaining a very complex syndromes, and it's not easy, and their contributions to the field are immense. So thank you very much. So the question posed to me was that about the intramural studies of ME/CFS and long COVID, and how the former is informing the latter. That means how what we've done about ME/CFS has been informing us about what we do about COVID. So I'll address that. The second part of the question, I think, has already been addressed very beautifully by Dr. Bates and Komarov regarding the overlap between the symptoms. So I'll just address the first part of it. And a total of 10 minutes, is that right? I want to make sure I keep things on time here for you. Okay, good. Okay, so the so in the intramural program, so the intramural program has its own, it's like a university of sorts. What we have is we have our own hospital, we have our own research labs, so we can bring in patients and we can study them and we can do research on them. So we've screened hundreds and hundreds of patients with ME/CFS, and then brought some in order to identify individuals that clearly had an infectious illness that precipitated their symptoms, and then brought them to NIH, admitted them, and then we've done all kinds of investigations on them to try and understand their disease. And in order to identify who these patients are, we actually have a panel of experts who will look at these case reports and then unanimously decide that this is the right kind of candidate to bring here. And Dr. Komarov has been critical in providing us that kind of information along with all the other panel members, and we appreciate all your help in that regard. So once we bring them in here, they then undergo a very detailed history evaluation. We take them off various kinds of medications they're on. We then take a very detailed history on them, and then we study them from head to toe. We do MRI scans, we do spinal taps to look at the spinal fluid, do a very detailed immune studies on them, virological analyses. We do muscle biopsies to try and understand the mitochondrial function, that if there's any kind of energy metabolism problem, as was mentioned earlier. We look at the lymphocytes and again look at their energy metabolism as well as the different types of lymphocytes and stuff. Look at cytokine analyses. Then finally, we put them on a treadmill of sorts, and we look at their exercise tolerance. Okay, and physical exercise as well as mental exercise tolerance. So on a functional MRI scan, we see how they can do cognitive tasks, and we also challenge them physically. So we've done that now in about 25 some patients and 25 controls, healthy volunteers. But each one of them takes a long time. We bring them in 2 different visits. They're here for 7 days, sometimes 10 days each or longer. And we're very grateful to these patients because they are undergoing a huge amount of investigation, where we're not providing any specific treatment for their symptoms. So it's a massive effort on our part as well as on their part as well. And without their help, this would not be possible. So I'm very grateful to each of those individuals who have participated in our studies. Now we are in the process of COVID. What happened is we were unable to bring in any more patients. So, but what we did was we took advantage of that in some way, said, okay, we've collected this massive amount of data, so we've now put together a task force. We have 4 different task forces that are now looking at all this data. So one looking at the pathophysiology, one looking at energy metabolism, and so on. So one is the immune panel workshop. And so each aspect of it is now being analyzed, and we're having regular meetings looking at that data and trying to make sense of it. And then ultimately, our hope is to see what we can combine together in order to make it publicly available. Now, when COVID started, of course, our efforts, I studied CNS infections, and I've worked on every single pandemic. And the problem is one doesn't go away and the other one gets piled on top of that. So started my career with the AIDS pandemic in the 80s, and then there's been you had Zika and Ebola, and and we had nodding syndrome, and you got all kinds of things. So we've dengue, we worked on all of them. Okay, and so now with COVID, of course, we diverted a lot of efforts towards it, but at the same time, we haven't lost our emphasis on ME/CFS. But through the COVID, we've learned a lot. I think that's the important thing, because we got autopsy brain tissues. We could look at what's happening there. With ME/CFS, it's been very hard to do so. We got a very unique cohort of individuals who otherwise didn't have respiratory problems, but died suddenly. So these are not individuals who had multi-organ failure and then all kinds of pathology in the brain, but actually these were individuals who otherwise could have potentially survived and could have developed long-term complications that could have resembled long-haul COVID. So we had unique opportunities to look at the brain in that way. And so we've published our findings already. And those things are informing us about how to now investigate our long-haul COVID patients. And we've learned from what we were doing with the ME/CFS patients to use that to study the long-haul patient. So it goes back and forth for both ways. You learn from one, you apply it to the other, and so on and so forth. Okay. So as Jamie mentioned, we have two protocols already in place. One is to just bring in patients with any kind of neurological problem that you have with COVID. They can come in and we will study them and try to figure out what it is. Then the second is, it's more specific. They are only those kinds of individuals who overlap with ME/CFS. So we have now a new arm within our ME/CFS study, which is going to be these long-haul COVID patients. But the criteria for entry is going to be the same as we have for ME/CFS. Now we added a few extra battery of tests because, as mentioned, they have some unique symptoms that the others don't have, for example, smell, taste, and the like. And then depending on how we see them, if we need to do additional testing, we'll add them in there. And so that has started as a massive effort. We've already, I've personally talked to over 200 patients myself. Our goal is to screen over 1,000 patients, 1,300 patients or so. We've done telephone interviews over 200 some. Then they're doing a questionnaire that they're going to fill out. And then we'll start bringing them in. And we've brought a few in on our other protocol because we wanted to study them nonetheless. But that's where we stand on this at the moment. I'll stop here.
Thank you so much. Now I'd like to introduce Jen, who is an RN who got COVID-19 in March and is now showing symptoms of ME/CFS. Jen?
Yes, thank you. It's really a privilege to be here today. And I must say I'm very humbled to speak about my long COVID experience, which is like so many countless others. So here's my story. I was working as a pediatric nurse in Seattle when I became ill on March 2nd of 2020. My initial illness was a fever and a cough for a couple of days. At that time, I was not eligible for a COVID test as I had not been traveling outside the country. I felt mostly recovered except for shortness of breath. By the time I tested positive at my workplace over 2 weeks from the onset, I had multiple symptoms, which we now know may be a predictor of long COVID. So SARS-CoV-2 was an insidious invader in my case. So here are some notable timestamps. At 1 month, my CT scan showed mild pneumonia. I had no voice, I had a metallic taste. And although my breathing difficulties worsened with oxygen at 90%, I managed to stay out of the hospital. This would be considered mild to moderate COVID. By May, at 3 months, my fatigue was so bad I could not sit up at a desk or keep my head held up. I had constant chest pressure, rapid heart rate, and my voice continued to fail. So I took leave from work. At that time, my pulmonologist suggested I check online support groups. The network of others like me was astonishing. I continued to convalesce, and after several months of rest and short walks, I felt well enough to try exercising. In September, at 6 months, I tried a bit of cardio and strength training, which is what I love to do. before COVID. Shortly after, I experienced what I now know to be a crash. For me, that was severe chest pain, extreme fatigue, feeling really out of it. I could not get off the sofa for several days. I had trouble concentrating. I could not recall 4-digit numbers. My activity level never recovered to my already low baseline. My remaining concerns today are orthostatic intolerance or dysautonomia or POTS, chest pain, fatigue, and neurologic issues. I have migraines, trouble concentrating, and I have light and sound sensitivities, as well as the looming reality that this may be a lifelong illness that is not well understood or studied. Along the way, advice from others with chronic illnesses and a physician friend with ME proved invaluable. The advice from the ME community was to pace, do not progressively exercise, know your energy limits, and do not breach them. And that the first 1 to 3 years were of most importance to avoid irreparable harm. Many of these people have been ill for decades and are now homebound. That was shocking to me. As a nurse and a patient with long COVID or post-acute sequelae of COVID, I've read everything I can, and I'm left with few answers from the medical community yet. It is clear that there's not enough evidence-based care informed by previous infectious illnesses and people with ME. With COVID-19, I'm still hearing it's a mystery. It took little time for studies on immune responses and clinical trials for the critically ill to emerge. Post-COVID clinics aimed at post-ICU follow-up, as well as long COVID or PASC, have quickly formalized. Still, my care is siloed into specialty areas for each symptom without addressing the root cause and proposing treatments. With the estimated 10% of COVID-19 infections developing into long COVID, I believe the system of healthcare is at an inflection point in treating chronic neuroimmune illness. So here's my main message. It is really encouraging that the NIH has $1.15 billion to spend on further PASC or long COVID research. But with symptomatology that is so similar to other post-viral illnesses or ME, it is imperative that the experience of the ME community be examined as well. Research needs to include the study of ME pathophysiology, which will hopefully lead to better treatments and outcomes for both ME and long COVID. Thank you.
Thank you so much, Jen. All right, and now we have Ashanti. Ashanti is an RN who has a diagnosis of ME/CFS. And take it away, Ashanti.
Thank you, Jamie. Well, since they saved the best for last, me, I better make these last few minutes worth your while. As Jamie stated, I am Ashanti Daniel, a disabled registered nurse and person with myalgic encephalomyelitis, or ME. I am also a single mother of 2, and in case you hadn't noticed, a Black woman. You may be wondering why I pointed out my race. Stay tuned and you'll find out. But first, let me start by taking you back to August 2016. I was living my best life, working in my dream career as a neonatal intensive care unit and congenital cardiac ICU nurse. I was an active single parent and working out vigorously 5, sometimes 6 days a week. I was literally the picture of health when the enterovirus family, specifically Coxsackie B virus, blindsided me, taking my career and life as I knew it with it. Imagine going from fitness enthusiast to being too weak and intolerant of being in an upright position without extreme dizziness, etc., that you have to eat your meals prepared and brought to you by someone else, laying down. Imagine having to shower sitting down on a shower chair and your heart still racing at 140 to 150 beats per minute while doing so. For context, normal adult heart rate at rest is 60 to 100 beats per minute. One of the hardest parts of this disease is that it inhibits my ability to be the mother I once was and would have been had this disease not turned our world upside down. Pre-illness, I never missed a baseball game my son was playing in. If he had a game at 8 a.m. and I worked the night prior, I would get off work at 7:30 a.m. and go straight to the baseball field. No sleep, none of that. I had to be there to support my baby. There was a time during my illness where I only made it to less than 5 of my son's games in a year, and he played almost every weekend. As a single mother, if I'm not there to support him, nobody is. Although my son may, quote, understand why I'm not there, it doesn't make my absence at his games feel any better to him. Now let's switch gears. I want to talk about a common misconception about ME that also applies to COVID. It's this idea that we should, quote, just push through. I did not know how detrimental pushing through is to people with ME until I attempted yoga about 5 months into my illness. This was prior to my actual diagnosis. Had I known about, quote, pacing, which is balancing activity and rest to prevent post-exertional malaise, or PEM, I could have saved myself from the permanent PEM that would follow. Real quickly, for those of you who are unsure of what PEM is, it is the worsening of symptoms following even minor physical or mental exertion. As a result of the PEM triggered by the yoga classes, I have never returned to the level of functioning I had prior to attempting yoga, and that was over 4 years ago now. Okay, now is the moment you all have been waiting for, the moment that I address the elephant in the room: structural racism and its impact on ME as well as long COVID. I'm assuming you all know what structural racism is. If not, Google it. Okay, seriously. As it stands right now, Black people with ME, a disease that has historically been perceived to be a, quote, white woman's disease, struggle to get diagnosed. Now we're adding a significant number of Black COVID long haulers to a healthcare system that is already inherently biased towards us. The COVID-19 pandemic illustrates the intersection of structural racism and health and highlights why we need to address structural racism now. Structural racism is the common denominator and underlying condition fueling disparities in COVID-19 and preventing Black people from being diagnosed with ME. Studies have shown 50%, that's half of white medical students and residents, false beliefs about biological differences between Black and white people. This is frightening, as these are the doctors of our future. Structural racism is a public health crisis, and clearly we have a lot of work to do to change that. Now, being completely transparent, I have to admit that as a nurse, I felt I was immune to structural racism in healthcare. That was, of course, until it happened to me. Although I was a nurse equipped with, quote, inside knowledge on how to navigate the healthcare industry as a patient, I still encountered physicians who did not take me seriously. 4 months into this illness and after multiple hospitalizations, I was finally able to get an appointment with an infectious disease physician. I arrived to this appointment desperate, but optimistic that I would get closer to finding out what was making my muscles profoundly weak, my voice unusually hoarse, causing cognitive dysfunction, triggering what I now know was PEM, causing bone-crushing fatigue, and so many other bizarre new symptoms. The infectious disease specialist talked to me for maybe 5 minutes max, ordered some blood work, did not physically examine me, and sent me on my way. To add insult to injury, I requested a copy of my medical records and learned that the infectious disease doctor had written my illness was likely psychosomatic. Wait, what? Excuse me, sir, but you only spent 5 minutes with me, did not even examine me, and could draw the conclusion that my symptoms were all in my head? In that moment, I thought to myself, if this could happen to me as a nurse, imagine what happens to other people of color, especially women who are not healthcare professionals. I was quickly reminded that being a nurse and, quote, one of them does not negate the fact that I am a Black woman. And due to implicit bias, which is subconscious prejudice, and structural racism in healthcare, I am far less likely to be believed and properly cared for than white men and even white women. I still make it a point to let any healthcare professional or provider in charge of my care know that I am a nurse, not expecting special treatment, but simply in hopes of ensuring basic, competent care. I could go on and on about these topics, but there isn't enough time now. I am available for future interviews though. In the interim, I will leave you with this. Research on long COVID should be combined with, not separated from, ME research, as post-viral illnesses have been around for decades, and there will be another after COVID. Combining research gives all of us the best chance of returning to our old lives. Please help us make that dream a reality.
Thank you so much, Ashanti. That was great. All right, so now we're going to have some time for question and answer, about 15 minutes. This is just a reminder to, when you're asking a question, say your name and your outlet and to whom your question is directed. Give me one moment and that'll give some people some time also to come up with their questions and type them in the Q&A or the chat. Okay, we've got a question from Court Johnson from Health Rising. This is for Dr. Nath. Can you say which, if any, tests from the Intramural MECFS study did not make it into the long COVID study? And has long COVID prompted you to add any studies to the MECFS cohort? So two-part question there.
Yeah. So almost everything is there. I can't recall that we took anything out purposefully. There may be some minor changes, but all the major studies overlap completely. And that's our intention, so that we can compare both cohorts together. In the MECFS, we had done some skin biopsies and we analyzed the first, I forget, to 10 or 12, and we didn't really see any abnormalities at all. So we then took that out. We weren't doing any more because it's an invasive procedure and it's not providing any information by doing it. But with the long haul, it's possible we were going to do skin biopsy. So that may be a difference because they're complaining of somewhat different symptoms and we don't really know if there's a neuropathy, small fiber neuropathy here or not. So that could be a difference between the two cohorts, I guess.
Okay. And the next question is from Ryan Pryor from CNN, and this is for Dr. Bateman. If long haulers are showing symptoms of MECFS, should the long COVID clinics be consulting with MECFS clinicians and researchers? And how important is this for treating long haulers?
Well, I think we're always available for help. I am very optimistic that what I've heard coming out of specialty long COVID clinics is a rapidly increasing insight about what's happening with those patients. So any of the long COVID clinics that focus on it and take the time with patients are going to learn very quickly. And hopefully we can be a resource to them. But I'm very, again, hopeful that we'll be, the problem is there aren't enough long COVID clinics, right? So the problem is when people try to go to primary care or try to go just to a specialist who just carves out their own little part. And so I'm hoping that these long COVID clinics, our clinic included, which is growing, can maybe collaborate and get information out there as quickly as possible as we learn it for management of on the primary care level.
Thank you. Our next question is from Lisa. Unfortunately, I don't think this is directed towards anybody, so I'm going to hold off on that question. This is from Michael Marshall, freelancing writer for Nature. Question for Doctors Bateman, Komarov, and Nath. And since Cindy is already up, we will ask her to go first. Do you think long COVID is a single illness, or are there several forms of it that research has not yet partitioned? And the same question applies to MECFS. Is that one disease or several? So Dr. Bateman?
I agree with Dr. Komarov on this. And that is, first of all, we have patients who had COVID who have obvious organ damage from the viral infection that may or may not resolve. And that group is, each one is going to take on the illness presentation of someone with damage to that organ. So already they start to be different. What I think we'll see is that the long COVID group, the group that develop other kind of multi-system illness that may relate to the brain or the autonomic nervous system or inflammatory process, I think we're going to see them take on a bit more of a homogeneous look. And I don't know, for that, that's my prediction. But I do think we need to look at all aspects of illness and not just lump it in a bucket.
Drs. Komarov or Dr. Nath, do either of you have anything to add to that?
I agree with what Dr. Bateman just said about both illnesses. MECFS, my guess, is an illness with a final common pathway that can be triggered by different things. So different triggers, but at the end of the day, the same group of physiologic processes that create the symptoms of the illness.
Yes, I couldn't agree more. I mean, they once they fall into that category, they probably are going to have similar pathophysiological mechanism. At least we hope that's the case. Otherwise, it'll be very hard to study them.
Yes.
But all the same, the thing is that there are a lot of post-viral syndromes. MECFS is only one of them. So you can get acute disseminated encephalomyelitis. It's a post-viral syndrome. You don't actually have virus. Guillain-Barré syndrome. You can get that. That manifests in these patients. Miller-Fisher syndrome. Cranial nerves can get involved there. Acute hemorrhagic encephalomyelitis. A number of patients can develop with the bilateral symmetrical lesions in the thalamus with hemorrhages in there. So there are multiple different syndromes that occur following a viral infection, and that's true with the COVID as well. And so MECFS has its own specific criteria as to how you are. According to the all clinical criteria, they're not a biological diagnosis, but it's one of many different manifestations of the infection, post-viral infections. That doesn't include the individuals who Dr. Bateman described who are acutely ill and have multi-organ damage. That's a separate category.
Okay, thank you. So this is for Drs. Komarov and Nath. And Dr. Nath, since you're already on, I will ask you to address this first. There are some reports that vaccinations can ease symptoms of long COVID. Is anyone collecting data on that? And if it is borne out, what might be the mechanism? And that is from Lisa Krieger from San Jose Mercury News.
So it's a very interesting observation. There's certainly more in the social media than there is published literature on it yet. But, Dr. Komarov and Bateman have a lot more experience than I do. But the way I understand it is that a number of the MECFS patients also similarly will report at least some temporary improvement following a flu vaccine or what have you. But in most individuals doesn't last very long. So I think the question for the long haul patients is the same. That, okay, yes, you did get better. How long did it actually last? That's the question we want to ask. Okay, now what's the underlying mechanism? I'm a virologist, so I think in terms of viruses. And what I'm impressed is that all RNA viruses can become restricted viral replication, whereby you have a viral infection and then you are not producing replicating virus. You're not infectious any longer, but you can have viral sequences that are still present in cells, and they're able to produce viral products, okay? And those viral products can then trigger the immune system. So that's a well-known phenomenon and can last many months, sometimes years with a potential virus. And there are many, many examples. For example, the Ebola, I'll tell you. So we saw all these patients who developed acute Ebola, they recovered, and then you could still detect RNA by PCR in the seminal plasma for 9 months, okay? But it was not being sexually transmitted. So while you could find that in majority of these individuals, it was defective viral sequences or partial viral sequences. Another good example is measles. Measles, you get an acute rash and you recover from it. And then a few months or years later, you can develop subacute sclerosing panencephalitis, which is a degeneration of the brain. And if you look for the virus everywhere, you can find it. You can do spinal taps or PCRs, blood, whatever, you don't find it. If the patient dies and you look at the brain is loaded with virus. It's everywhere. But it's not infectious virus. It's restricted viral replication, okay? And it's transmitted from one cell, one neuron to another. So that's the classical example. So I think, so that's at least one possibility as to how these patients, there's certainly a lot of other explanations that you can have. For example, the immune system itself, just cranking up the immune system may in some ways negate some of the other aspects of the immune system. There are many aspects of the immune system, right? So you can find multiple explanations. The important thing is that you got to go in there unbiased and look at all possibilities and try to investigate and determine what the phenomenon really may be able to teach us.
Dr. Komarov, do you have anything to add to that?
Two things. To emphasize the theory that Dr. Nath just put forward. This morning in the journal Nature, a study showing that with COVID, exactly this happens with viral remnants that remain in the gut, eliciting an ongoing immune response to them from Michelle Nussenzweig's lab at Rockefeller. In terms of the immune explanation, part of the immune system's role is to quiet down an overactivated immune part of the immune system. And the immune system is going back and forth in terms of how activated it is. If you believe that the symptoms of this illness are caused by a chronic low-grade activation of the immune system in the brain, which is a theory that I think is probably going to prove to be right, then vaccines may, at least temporarily, increase the number of those immune cells that quiet things down for a while and quiet the symptoms down for a while. Wild guess.
I will just quickly ask any of our patients if they have gotten the vaccination and experienced a remission of symptoms. You can just shake your heads if that's a no.
I have not done the vaccination.
Okay. And Jen, have you?
I just had one dose. It's still not widely spread yet. So, but definitely an immune response was felt the first dose.
Okay, thank you. I will personally add that on the rare occasions that I do manage to actually catch something, the original response does seem to cause remission of ME symptoms temporarily. So it's interesting, the immune activation narrative there might be something there. All right, thank you. The next question is from Miriam E. Tucker from Medscape Medical News. I do not see this directed to anybody, so I will open it up to everyone. Should clinicians be routinely evaluating post-COVID patients for a possible ME/CFS diagnosis? And should that include people who have symptoms but never had a positive COVID test? What would you say to physicians who express skepticism about long-term symptoms when laboratory tests come back negative, or who ascribe them to psychological causes? I assume that is directed to our clinicians. So Dr. Bateman, we haven't heard from you in a bit. Would you like to take that first?
Certainly. I do think I would love to see clinicians evaluate patients to see if they meet criteria for ME/CFS. Unfortunately, understanding of ME/CFS is not globally distributed among all the medical profession. Hopefully, discussions like this will inform people. I would at least like to see clinicians assessing the individual symptoms carefully. And the most commonly missed aspect of illness, besides exercise intolerance in PEM, is orthostatic intolerance. And it really doesn't matter what the cause of the orthostatic intolerance is, it's amenable to supportive treatment. And it's one factor of illness that contributes to a severely impaired function. So my plea would be to all physicians for sure to assess for orthostatic intolerance and gain an understanding about activity management and avoiding post-exertional malaise symptoms.
Thank you. Do either of our researchers or clinicians have anything to add on top of that?
No.
So I'd like to say something. So in the second part of Miriam's question is important, although she had primarily in her second part addressed it largely to Dr. Bateman and Komarov. I think the second part of the question is very important. And what she's asking is that what would you tell physicians who do their testing and patients come back negative, okay? And then they attribute it to psychological. And I think that's a problem that all these patients face. They're going to physicians' offices. They're testing negative. They have a lot of symptoms. And these physicians are telling them, maybe this is all psychological because I can't really figure out what's wrong with you. So if you look at it from the physician's perspective, this family doctor or internist, whoever it is, they're trapped themselves. They don't know what to do, right? They can do all the testing that is available to them. It comes back negative. They say, okay, I believe your symptoms. I'm going to send you for your chest x-ray or this and blood work or whatever it is, and this, that, and the other. Everything comes back negative for them. They don't know what to do. So their default thing is, okay, maybe it's psychological, maybe I'll send you to rehab, or maybe you do some exercise, or why don't you try this medication, some symptomatic thing, and maybe it'll help you. So but that physician can only order tests that are available to them through their labs, right? So I think what these physicians need to do, and probably is that say, okay, if this is the best that I can do, I can handle your symptoms symptomatically, and I treat them symptomatically, but then refer them to specialists who are taking care of these patients or to research studies. And right now, there are lots of research studies popping up everywhere for long haul patients. And the ME/CFS patients can be seen there as well. So because there we are going to do more thorough investigations, try to do research type investigation, and try to figure out the bottom line. Is it autoimmune? Is it some novel antigen that's being expressed or being triggered? And so there are a lot of things we can do. But I think that's the way to be able to handle these kinds of patients. We can't, if you just push the blame on the poor family doctor internal medicine person, it doesn't really help the process.
Can I add something?
Yes,
Yeah.
absolutely.
There's really two issues about positive tests that I would like to refer to. One is whether or not people had a documented COVID infection. And we just have to let go of that in 2020 because way too many people didn't have access to testing or the timing of their testing was not amenable to an objective diagnosis. But the second point is if people meet criteria for ME/CFS, then it's irrelevant because ME/CFS is not defined by lab tests either. We presume that it's a post-infectious syndrome, but we all know, those of us who understand the illness, that maybe other than orthostatic testing and some of the other things we do, this is a clinical diagnosis, ME/CFS, that's not reliant on identifying the infectious agent that triggered it.
Yeah, I couldn't agree more. I think that's very true. Yeah.
All right, we've got two more questions and then we're gonna close it out. So let's be mindful of everybody's time. Lauren Clark, who is asking from Women's Health UK, asked this question of Dr. Nath and Dr. Komarov. Early research is indicating that disproportionately more women than men are suffering from long COVID, and ME/CFS affects 4 times as many women as men. Is any research focusing on why this might be the case? For example, hormonal differences. Could understanding the gender differences help provide the key to understanding what is happening? Dr. Komarov, would you like to attack that first?
Well, I'm not aware of any research that's underway now, but perhaps Dr. Nath is. And my bet is that with this new support at NIH, you're going to see research studies focused on exactly that question. My theory is this, that most, not all, but most autoimmune diseases are more common in women. And when there are animals that get diseases like the human disease, they're much more common in the females of the animal species. So if some of the symptoms of this illness are caused by autoantibodies, as I bet they are, then that could be some female hormones may predispose women to autoantibodies and autoimmune disease more than they do men.
Anything to add
Yeah,
to that,
so,
Dr.
yeah,
Nath?
I agree. So the thing is that it's not unique to long haul COVID. The gender differences in loss of diseases, people are recognizing them. It used to be that our sample sizes were never large enough to be able to address these things. There's a huge amount of interest, just as Dr. Komarov mentioned, in multiple sclerosis and rheumatoid arthritis, and so I think there's a common phenomenon in all these diseases as to why women are more affected than men, or in other diseases where men are more affected than women. So I think there's being studied now very extensively, and I'm sure we'll have more better answers for these things soon.
I will add one thing to that myself, which is that in a large Norwegian study that showed the ages at which people were most likely to be diagnosed, you have spikes in adolescence and in the late 20s to mid 30s, both times when hormones fluctuate a good deal. And that might give us some cues as well as to why. women are more affected, more often affected. All right, this last question is for Jen and Ashanti, and it is, what are one or two things that reporters can do in order to cover your stories most sensitively and accurately? So maybe each one of you can pick one thing that would be really helpful to keep in mind when you're writing. And I'm not going to call on one of you. Whoever feels like they've got it. All right, Jen, go for it.
Part of this is my own feeling of status, because I'm a nurse. I had the in to getting my test done at my workplace. So I think it's really important to kind of piggyback on Dr. Bateman's answer. Not everyone was able to get a test. If you're sick for 12 months, this is March, we're all at 12 months. You need to believe them and not necessarily ask if they were tested, if they had a PCR test. We also know that some of those tests weren't super accurate at the beginning. So I guess that's my feeling on that. I am very lucky that I was able to get a test, and I can tell you several of my doctors have already asked, in order for me to be seen, I had to prove that I had a test.
Thank you, Jen. Ashanti, what would you like people to keep in mind?
I would like people to keep in mind to evaluate and really sit with their own implicit biases, because I feel that, hey, reporters are humans just like the rest of us. And I find there are a lot of people who are sick with ME who have had family members that don't believe them, doctors that don't believe them, et cetera. So implicit bias exists. And especially because some of the things that we describe, that we experience, they don't make any sense to anyone who has never experienced any uncontrollable body failure. So it's really, really important for you to really try to take a step back, examine what your own biases are, and try to remove that from what you're writing, and really try to have empathy with the patient whose story that you're covering, no matter how outlandish something that they say sounds.
Thank you. Thank you, Ashanti. All right, so just to close up, it's clear from our conversation today that ME/CFS has to be part of our overall conversation regarding long COVID. Some people with long COVID are going to go on to be diagnosed with ME/CFS because ME/CFS was an expected outcome of the pandemic, and because research in one disease is going to be essential to inform the other. Only through integrating our knowledge and experiences can we make progress to understanding what causes these different post-viral diseases and lead to effective and available treatments for everybody. I want to thank all of our panelists for being here with us today and putting themselves out there and on the line. We really appreciate it. And thanks to the journalists for joining us today and listening to everybody's stories. We hope you have a great rest of your week. Thank you so much for joining us.
Thanks for organizing it.
Thank you.
I must thank Adrienne Tillman, our press lady, did a fabulous job getting it all ready.
We absolutely did. And if anyone has follow-up questions, please email Adrienne at press@meaction.net, and she'll be able to answer those questions. Thank you so much, Jamie, for moderating. Thank you to the entire panel. And on behalf of ME Action, thank you all for attending. And we're happy to answer any follow-up questions that you have. Have a great day.